The next PowerPoint will cover the thigh and knee. The knee is two joints, the patellofemoral joint and the tibiofemoral joint. Pictured here in a radiograph is obviously the knee. We can see the femur, the tibia, here's the fibula, and here is an outline of the patella. Here is another outline of that patella. This is a left side view. The patella articulates with the lateral and medial condyle of the femur in anatomical position. The patella has three facets. It has a large lateral facet that articulates with the lateral condyle, a medial facet that is actually in the middle that articulates with the medial condyle, and then there is an odd facet that is most medial on the articular surface of the patella. The odd facet is odd as it does not articulate with the medial condyle until approximately 135 degrees of flexion. As the tibia rotates during flexion, the patella will rotate as well in order to articulate with the medial condyle. As you can see, the lateral condyle and medial condyles are of different lengths. These differences in lengths make the knee a sloppy hinge joint. It is considered a hinge as its true osteokinematic motion is flexion extension, but with extension there is some tibial external rotation that occurs, and with flexion there is some tibial internal rotation that occurs. The knee is a synovial joint. It has a joint capsule, and stabilizing the knee are both extra-articular structures, so structures outside of the joint, and intra-articular structures, or structures between or within the joint. First, we will discuss the extra-articular structures associated with the knee, so structures outside of the joint complex. First, we have the tendon of the rectus femoris that attaches superiorly on the patella. And between the patella and the tibial tuberosity, we have the patellar ligament. Medial to the patella, we have the medial retinaculum. The medial retinaculum is made up of the aponeurosis from the vastus medialis. And lateral to the patella, we have the lateral retinaculum, which is made up from the aponeurosis of the iliotibial band and the vastus lateralis. On the medial aspect of the knee, we have the medial collateral ligament or tibiocollateral ligament. This ligament runs from the medial epicondyle and has a broad attachment on the medial aspect of the proximal tibia. The medial collateral ligament also attaches to the medial meniscus, such that injuries to the MCL may also affect the meniscus, and likewise injuries to the medial meniscus may also affect the medial collateral ligament. An injury to the ACL, which is an intra-articular support, the medial meniscus, and the MCL is known as the terrible triad. Lateral to the joint, we have the lateral collateral ligament, which is another extra-articular structure. The lateral collateral ligament is also known as the fibular collateral ligament. The fibular collateral or lateral collateral ligament runs from the lateral epicondyle to the fibular head. The lateral collateral ligament does not attach nor come into contact with the lateral meniscus, as the tendon of the popliteus wraps the knee deep to the lateral collateral ligament. Posteriorly, there are two ligaments, the oblique popliteal ligament, which is right here, the oblique popliteal ligament, and the arcuate ligament, or the arching ligament. So anteriorly, the extra-articular structures include the patellar ligament, the tendon of the rectus femoris, the medial and lateral retinaculum, the medial collateral ligament and lateral collateral ligament. Posteriorly, you have the oblique popliteal ligament and the arcuate ligament. Intra-articular structures of the tibiofemoral joint include the medial and lateral meniscus. These are C-shaped fibrocartilage structures. The meniscus contours for the femoral condyles. Joining the medial and lateral meniscus on the anterior side within the joint is the transverse meniscal ligament. These basically hold the menisci together on the anterior side of the joint. Suturing both medial and lateral meniscus to the tibial plateau are the coronary ligaments. Again, these are like sutures that suture around the tibial plateau like a crown, hence the name coronary ligament. These coronary ligaments both secure the meniscus to the tibial plateau while still allowing for movement during flexion and extension of the knee. Posteriorly, we have the posterior cruciate ligament along with the posterior meniscofemoral ligament. Anteriorly, we have the anterior cruciate ligament. Now, the anterior cruciate ligament prevents anterior translation or anterior movement of the tibia on the femur. The PCL and posterior meniscofemoral ligament prevent posterior translation of the femur, of the tibia on the femur. An interesting thing to note is that the capsule of the knee goes anterior and follows the meniscus into the knee, if you will, and then comes back out. This leaves the PCL and the posterior meniscofemoral ligaments as extracapsular, or outside the capsule. So they are considered intra-articular, however, they are extracapsular or outside the capsule, such that injury to the ACL will cause swelling. That swelling may stay within the joint, causing pain and decreased range of motion. Injury to the posterior meniscofemoral or PCL may also cause pain and swelling, but that swelling will most likely be in the posterior knee in what's known as the popliteal fossa. Aside from the tibiofemoral component of the knee, there is also a patellofemoral joint associated with the knee. The patellofemoral joint is stabilized by extra-articular structures of the knee. Those structures that stabilize the patellofemoral joint include the patellar ligament, the tendon from the rectus femoris, the medial retinaculum, which is formed by the aponeurosis of the vastus medialis, and the lateral retinaculum, that's formed by the aponeurosis of both the vastus lateralis as well as the iliotibial band. Length and or strength issues may lead to improper patellar tracking. So patella normally should track straight superior to straight inferior. If the patella should track laterally or medially, the patella may wear where wear is not intended, causing pain and decreased function. Just as in previous joints discussed, the knee has bursa associated with it, which reduce friction. We'll start superior to the patella with the suprapatellar bursa. The superior patellar bursa is located between the quadriceps tendon and the distal femur. The suprapatellar bursa is attached to a muscle called the articularis genu. The articularis genu holds the suprapatellar bursa superior and has the ability to retract and pull the suprapatellar bursa superior as the knee goes into extension and the patellar rises within the patellar groove. Between the skin of the knee and the lower part of the patella, we have the prepatellar bursa. Prepatellar bursitis is common in workers who spend a lot of time on their knees, such as carpet layers and tile setters. Inferior to the patella, we have two bursas, a deep infrapatellar bursa and a superficial infrapatellar bursa. The deep infrapatellar bursa is at the top of the tibial tuberosity, deep to the patellar ligament. The superficial infrapatellar bursa is located between the skin and the tibial tuberosity. Inflammation of the superficial infrapatellar bursa is known as clergyman's knee, as the church kneelers formerly did not have any padding, so clergymen would kneel with their tibial tuberosities directly on these wooden kneelers, and it could cause or would cause bursitis, inflammation of that bursa at the tibial tuberosity. Posterior and inferior to the patella, there is an infrapatellar fat pad. The infrapatellar fat pad is also innervated, and when inflamed, this fat pad can cause pain behind the patella. If you simply extend your knee, you will see the infrapatellar fat pad bulge out on the medial and lateral sides of the patella. Posteriorly, we have the gastrocnemius bursas. There is a medial and lateral gastrocnemius bursa that lies under the femoral condyles, which is also under the medial and lateral heads of the gastrocnemius. On the lateral side, there is a popliteal bursa. The popliteal bursa is often an extension of the lateral gastrocnemius bursa. The popliteal bursa sits deep to the tendon of the popliteus muscle. Shown in this picture, you can see the tendon of the popliteus here. The popliteus muscle actually attaches on the proximal posterior tibia. Its tendon runs lateral. The popliteal bursa prevents friction at the knee joint as the popliteus internally rotates the tibia during gait. Not pictured is one more bursa you'll be responsible for, and that is the pes anserine bursa. The pes anserine is a common tendon for three muscles, the sartorius, gracilis, and semitendinosus. The sartorius, gracilis, and semitendinosus attach to the proximal anterior medial tibia via this pes anserine common tendon. It is called the pes anserine because it looks like a goose's foot. Pes meaning foot, anserine meaning goose. Next we're going to look at the thigh and its compartments along with the muscles, blood supply, and nerve supply of each compartment. In the anterior compartment, there is a space known as the femoral triangle. The femoral triangle is framed by the sartorius laterally, the adductor longus medially, and the inguinal ligament superiorly. The floor of the femoral triangle is made up of two muscles, the iliopsoas and the pectineus. Nerve supply to this femoral triangle comes from two nerves. Motor to this area is via the femoral nerve. Sensory to the femoral triangle is from the femoral branch of the genitofemoral nerve. As you recall, the genitofemoral nerve came from L1, L2 within the lumbar plexus. Also running in the femoral triangle is the femoral nerve, femoral artery, and femoral vein. Here's another picture of the triangle. This is an old picture from Gray's Anatomy. Here is the sartorius. Here's adductor longus, and there's the inguinal ligament. The floor would be the iliopsoas, and deep to this complex is the pectineus. Here you see the femoral nerve, femoral artery, femoral vein. One of the main veins off of the femoral vein is the great saphenous vein. The great saphenous vein drains the medial dorsum of the foot, medial leg, and medial thigh back into the femoral vein. It's one of the main veins of the lower extremity. This vein is another vein used in cardiac bypass. The thigh has three main compartments: the anterior compartment, the medial compartment, and the posterior compartment. The nerve to the anterior compartment is the femoral nerve. The femoral nerve innervates all of the muscles in the anterior compartment. The femoral nerve starts as the spinal nerve of L2, L3, L4. It goes through the pelvis and under the inguinal ligament to and through the femoral triangle, where it rapidly disperses its branches to the muscles in that compartment. On the way through the pelvis, the femoral nerve runs between the psoas major and the iliacus muscles and provides motor innervation to both of those. In general, the femoral nerve innervates both flexors of the hip and extensors of the knee. It gives off muscular branches to the sartorius, pectineus, iliopsoas, and the quadriceps muscles: vastus medialis, vastus lateralis, rectus femoris, and vastus intermedius. The femoral nerve in addition to providing sensory from the anterior thigh, gives off a large cutaneous branch called the saphenous nerve. The saphenous nerve goes down the medial aspect of the lower leg with the femoral artery and femoral vein. These structures run deep to the sartorius and through the adductor muscle and adductor hiatus to the medial knee, where the saphenous nerve provides sensation from the medial knee. Saphenous nerve entrapment can come from knee surgery. It can come from surgery to remove part of the great saphenous vein in the case of heart surgery. It can become from trauma to the medial leg or medial knee as well. Saphenous nerve pain often presents itself very similarly to medial meniscus pain. Your examination will have to differentially diagnose a saphenous nerve problem from a medial collateral ligament or medial meniscus problem. Blood supply to the entire lower extremity comes via the femoral artery. As you'll recall, off of the abdominal aorta, we had an external iliac and an internal iliac artery. The external iliac artery, once it descends inferior to the inguinal ligament, will be called the femoral artery. The femoral artery courses down the anterior thigh with the femoral vein and the saphenous nerve deep to the sartorius, where it then goes through the adductor hiatus to become popliteal in the posterior knee. Fairly soon after the femoral artery passes the inguinal ligament, it gives off a deep branch called the profunda femoral artery, very similarly to how the brachial artery gave off the profunda brachii or deep brachial artery. The femoral artery gives off the profunda femoral artery, which courses down the thigh. The profunda femoral artery branches off perforating arteries. These perforating arteries perforate anterior to posterior through openings in the adductor magnus in order to provide blood to the posterior compartment. So the artery of the anterior compartment is the femoral artery. The artery to the posterior compartment is the profunda femoral artery. Off of the proximal end of the profunda femoral artery, we have arteries that provide blood to the hip joint. These arteries include the medial femoral circumflex and the lateral femoral circumflex. The lateral femoral circumflex branches off a descending, a transverse, and an ascending branch. The ascending branch of the lateral femoral circumflex meets up with the medial femoral circumflex to provide blood around the greater trochanter. So blood to the greater trochanter, lesser trochanter, neck of the femur. The muscles of the anterior compartment include the sartorius. The sartorius flexes the hip, abducts the hip, and externally rotates the hip. Because of its attachment distal to the knee, it will also flex the knee. The sartorius runs from the ASIS and is part of the pes anserine group. The sartorius, when it contracts, is said to place the hip and knee in the tailor's position. Hip flexion, abduction, external rotation, and then flexion of the knee, similarly to how a tailor might sit. The pectineus is next. The pectineus is a deep hip flexor and adductor. It goes from the pectineal line of the innominate to the femur. The rectus femoris is a hip flexor, especially to 90 degrees. It is also a knee extensor. The vastus lateralis is the largest of the quadricep muscles. It is a pure knee extensor. Vastus medialis, which is much smaller than the vastus lateralis, is also a knee extensor. The functional component of the vastus medialis is called the VMO, or vastus medialis obliquus. This is a distal component of the vastus medialis where the muscle fibers run more obliquely. Because the vastus lateralis and vastus medialis exert a superior pull on the patella, the vastus medialis, due to its much smaller size, is oriented more obliquely, such that the force from the oblique fibers match the much greater force from the vastus lateralis, so as they contract, the patella will course straight superior during knee extension, and then back inferior during an eccentric flexion. Last, the vastus intermedius, that's mostly connective tissue, but also a knee extensor. The sartorius, pectineus, rectus femoris, vastus lateralis, vastus medialis, including the VMO, and vastus intermedius are all part of the anterior compartment, and all are innervated by the femoral nerve from L2, L3, L4. On this picture, the sartorius, pectineus, rectus femoris, those are all potential hip flexors. Vastus lateralis, vastus medialis, vastus intermedius are all knee extensors only, as none of them cross the hip. The medial compartment contains the adductors of the hip. Each of these muscles is in part innervated by the obturator nerve, which also has an L2, L3, L4 component. Gracilis is first, followed by adductor longus, adductor brevis, and the largest of the adductor group, the adductor magnus. The adductor magnus is such a large muscle. It carries dual innervation from both the obturator nerve and the tibial nerve. As you'll recall, the tibial nerve was a portion of the sciatic nerve. The obturator nerve not only provides motor to these muscles, it also provides sensation from the medial thigh. So here is a graphic showing that obturator nerve, starting at L2, L3, L4, going through the pelvis, through the obturator foramen, and then innervating motor to those adducting muscles of the thigh. You can see it also has a cutaneous branch that carries sensation from the medial thigh. So sensation from the medial thigh, obturator nerve. Sensation from the medial knee, saphenous nerve. Sensation from the anterior thigh, femoral nerve. Sensation from the femoral triangle is the femoral branch of the genitofemoral nerve, and sensation to the lateral thigh would be via the lateral femoral cutaneous nerve. The last compartment is the posterior compartment. So the posterior compartment is basically the hamstring muscles. The nerve within the posterior compartment is the sciatic nerve. As previously discussed, the sciatic nerve is actually two nerves wrapped in a fascial sheath. These two nerves are the tibial nerve and common fibular or common peroneal nerve. For ease of understanding, I'll refer to the common fibular nerve as the common peroneal nerve consistently from here on out. The nerve to most of the muscles in the posterior compartment is the tibial nerve. It innervates all but one head of one muscle. In looking at the muscles of the posterior compartment, these are going to be muscles that not only flex the knee, but extend the hip. The first muscle is the biceps femoris. This is the lateral hamstring, if you will. The biceps femoris has two heads, a long head, which is innervated by the tibial nerve, and the short head, which is innervated by the common peroneal nerve. As you see here, here is the biceps femoris going laterally. Its short head is going to be right in here. You can see the division. There's sciatic. There's a continuation of tibial, a continuation of common peroneal. This common peroneal nerve courses right with the short head of the biceps femoris, such that it is ideal for providing motor innervation. The semimembranosus is next. It runs from the ischial tuberosity to the posterior tibia. The semimembranosus is considered a medial hamstring. It, like the biceps femoris, extends the hip and flexes the knee. Last, the semitendinosus, also running from the ischial tuberosity. It runs distally and is part of the pes anserine. Semitendinosus is also considered a medial hamstring. Now, the biceps femoris attaches to the fibular head. The fibular head is part of the proximal tibiofibular joint. That joint ties the fibula to the tibia such that contraction of the biceps femoris can facilitate external rotation of the tibia. The semitendinosus, semimembranosus, those medial hamstrings, when they contract, they can facilitate internal rotation of the tibia. This will be important information as in future semesters, when you manual muscle test the medial hamstrings versus the lateral hamstrings, you can bias the manual muscle test by either externally or internally rotating the tibia during the test. The biceps femoris, semimembranosus, semitendinosus are all tibial nerve innervated, with the exception of the short head of the biceps femoris, which is common peroneal nerve innervated. The last muscle in this area is the popliteus. The popliteus attaches to the posterior proximal tibia. Its tendon wraps laterally, deep to the lateral collateral ligament. When it contracts, it causes internal rotation of the tibia. It causes what we call unlocking of the knee. In the earlier part of the presentation, I said the knee was a sloppy hinge. In addition to knee extension, or coupled with knee extension, we have external rotation. Coupled with knee flexion, we have internal rotation. The popliteus is said to unlock the knee by initiating internal rotation of the tibia during gait as we go from full extension to flexion. The popliteus therefore unlocks the knee by creating the internal rotation that makes flexion of the knee possible. Here is a graphic showing the sciatic nerve and its path down the posterior leg. The tibial nerve portion of the sciatic, again, innervates all of the posterior compartment muscles, with the exception of the short head of the biceps femoris, which is common peroneal nerve. The sciatic nerve splits about 3 to 4 inches above the hinge of the knee, or above the tibiofemoral joint. It is there that it splits into common peroneal and continues posteriorly as tibial. The common peroneal nerve will wrap distal to and posterior to the neck of the fibula, wrap around to split into the superficial peroneal, which innervates the lateral compartment of the leg, and deep peroneal, which innervates the anterior compartment of the leg. The peroneal nerves will then go on to provide motor and sensory to and from the top or dorsal surface of the foot. The tibial nerve component of the sciatic will continue down the posterior leg, provide innervation to both the superficial and deep muscles of the posterior compartment of the leg, before it splits into the medial and plantar nerves that innervate the muscles on the bottom of the foot, or the plantar muscles of the foot. As we previously covered, blood supply to the posterior compartment of the thigh is from the deep femoral or profunda femoral artery that comes off of the femoral. The profunda femoral artery branches off perforating arteries that perforate foramen in the adductor magnus to provide blood to the posterior compartment or hamstring muscles. The femoral artery continues as femoral down the anterior compartment deep to the sartorius. It, along with the saphenous nerve and femoral vein, pierce through the adductor hiatus. At the level of the adductor hiatus, this artery will then become popliteal, shown here. The popliteal artery will branch off five branches to the knee joint itself. Branches to the knee joint off of the popliteal artery in the posterior knee are called the genicular arteries. You have a superior lateral genicular, a superior medial genicular, an inferior medial genicular, and an inferior lateral genicular, along with a middle genicular. So the geniculars are simply named by where they are anatomically. Again, the genicular arteries are non-muscular branches. They are branching to the knee joint itself. The area posterior to the knee is known as the popliteal fossa. We will talk about it as we talked about the cubital fossa in the elbow. The popliteal fossa is bordered superiorly on the lateral side by the biceps femoris and superiorly on the medial side by the semitendinosus and semimembranosus muscles. The popliteal fossa is bordered inferiorly on the medial side by the medial head of the gastrocnemius and on the lateral side inferiorly by the lateral head of the gastrocnemius and the plantaris. There are a number of structures that run through or form the popliteal fossa. The floor of the popliteal fossa is the popliteus muscle. Running through the popliteal fossa includes the sciatic nerve, which then divides into a common fibular nerve or common peroneal nerve and a tibial nerve. Arterial supply within the fossa is via the popliteal artery, which is an extension of the femoral artery. And then there are 5 branches to the knee joint itself off of the popliteal artery, and those are the 5 genicular arteries: superior medial, superior lateral, inferior medial, inferior lateral, and middle geniculars are all coming off the popliteal artery. Running alongside the popliteal artery is the popliteal vein. Draining into the popliteal vein is the small saphenous vein. The small saphenous vein is a superficial large vein that drains from the lateral foot, posterior lateral leg, and it drains into the popliteal vein. Again, the floor of the popliteal fossa is the popliteus muscle. There are 2 sensory nerves that run through the popliteus as well. The medial sural nerve is a sensory nerve off the tibial nerve, and the lateral sural nerve is a sensory nerve off of the common peroneal nerve. This makes sense because the tibial nerve is medial, so medial sural comes off tibial. The common peroneal nerve is lateral, so the lateral sural comes off of common peroneal. So injury to the popliteal fossa may affect any of its contents. Once again, the contents of the popliteal fossa include the sciatic nerve and its branches, the common fibular nerve and the tibial nerve. Coming off the common fibular nerve or common peroneal nerve is the lateral sural nerve, which is a sensory nerve. And coming off the tibial nerve is the medial sural nerve, also a sensory nerve. Running through the popliteal fossa is the popliteal artery and its 5 genicular branches, along with the popliteal vein, the small saphenous vein, which drains from the leg, drains into the popliteal vein, and last but not least, the floor of the popliteal fossa is the popliteus muscle. In the next slideshow, we'll be talking about the leg as well as the foot.